the professional football players, over 60 to 70% of them are exposed to opioids throughout their career, and many of them remain on opioids. And the National Football League has recognized this, and they also recognize that many of their players are actually using cannabis for recovery after competition. And so, but there is absolutely no evidence to support this. And so in June of last year, they announced they were allocating $1 million to study the effects of cannabis, with pain being a high priority. They had 106 applications, and they invited 10 to come in for a oral presentation. I was one of the 10 selected, and then they gave out 2 grants. It was UC San Diego and one in Toronto, Canada. The one in Toronto, Canada is focusing on post-concussion recovery, and we are focusing on pain. So the purpose of this is to present the study that I'm about to do. I'm not going to be able to give you any data right now, but it was just announced in February early February of this year. Okay, well, it's not working. There we go. Well, okay, so this is an overview. So there are a lot of anecdotal reports of professional and amateur athletes using cannabis and cannabinoids for recovery after injury. However, again, there's no controlled studies. And this proposal study examines the effects of cannabis on sports-related injuries, and the first of a kind to incorporate it in real life. It's going to be in elite athletes from high contact sports. We are going to use rugby players. It was not feasible to use NFL players at this time. Cannabis we've administered similar to how players say they're using it. Effectiveness evaluated following competition, game-related injuries, and then we will evaluate pain and other key components and outcomes in real life. So this is not an easy thing to do, but the feasibility is going to be enhanced by a research team, the Center for Medicinal Cannabis Research. We've been doing over 2 decades of research. We have a very robust clinical research team, and we have really good ties to the professional rugby community. San Diego has a professional rugby team. We also are looking at 2 other in Washington and Los Angeles. The study aims, we will be comparing THC, CBD, and a combination of CBD, THC against placebo. Using a real-world focus, these are the 4 main outcomes: pain, pain relief, physical functioning, and perception of treatment efficacy. We're also going to be measuring cognition, sleep, mood, and we're taking a little step further. We're actually going to be drawing blood from these rugby players, both pre and post-injury, to look at biomarkers, and mainly inflammatory markers. Our hypothesis is that THC and THC-CBD combinations will be superior to CBD alone or placebo. And also the inflammatory biomarkers will be reduced in the THC arm. The rationale is I just didn't choose this 4% just grabbing it. We've done a lot of research looking at what the optimum dose is. And when you get above 4%, you actually start having negative effects. So you can actually have worsening of pain. But at 4% and below seems to be an effective therapeutic window. Studies on the effect of CBD are almost non-existent. And I think the doses required for CBD to be effective are cost prohibitive. And then there's anecdotal reports of benefits of THC combined with CBD. So the overall design, it's going to be a randomized, double-blind, placebo-controlled crossover design. In professionally rugby players, we are going to use around 50 to 60. Our power analysis, the thing we can get, because it is a crossover design. And then they're going to be given 4 bottles, one with 4%, 12%, and then the combo and placebo. We're going to have them vaporize it with the Mighty Medic, and they will be vaporizing up to 48 hours over competition and then stop it after that. And then they'll wait for their next competition and injury. And then we'll assess these primary and secondary outcomes via ecologic monetary assessment. So this is going to be real life. You got to understand, this is really, these are elite athletes that their priority is to their competition and their performance. We can't be doing a study that's going to interfere with that. So we will be doing all of this in their home with this EMA. And then we will be getting the drug from NIDA. However, we are talking to some other DEA approved manufacturers and distributors that we may be using. Primary outcome, pain, functional status, and these will all be used. They're very, the questionnaires are using are very brief and can be assessed, completed on the EMA. And then these are the secondary outcomes. This smartphone app will be able to track cognition to see after they dose it, just if they're having any cognitive effects. We will be measuring sleep with actigraphy, mood. We'll be drawing blood to actually look at the levels of THC and CBD in their blood, as well as the inflammatory biomarkers. The inclusion criteria are 18 years of older, rugby players. The exclusion, we have to exclude these in the professional rugby here in the US. There are international players. We have to exclude them if their country bans cannabis. So the study protocol, pre-game, we will assess their pain. We will be giving them the EMA, doing the baseline assessments. And then post-game, if they have a pain score of 3 or greater, then we will have a phlebotomist on site. We will get blood from them, and then we will have them vaporize it at home, and then we'll start the assessments. This is challenging also because understand rugby players after their competition, they like to go and chill out and go to the bar, and they're probably going to have some alcohol we can't tell them they can't do that. We will try to factor that in, but we'll tell them don't dose this until you're in your home and ready to go to bed. And then they will dose it AM and PM 2 days for 48 hours later, and then they'll stop. They can dose it up to 4 times a day if they want, and then we will be doing more blood draws, have the phlebotomist back in there. This is the EMA. The questionnaire has been developed in the CMCR with over 2 decades of data. And it's quite easy to use. It has 2-way communications with study staff. If the participant has questions, then somebody will be available. Also, this guided puffs, it will actually guide them to dose it. Inhale, hold it, exhale, inhale, hold it. If they do it, we're going to use a Fulton puff, which is 4 puffs, 10 seconds held, and it'll try to standardize the dose. This is the research team. Dr. Thomas Marcotte is the co-PI with me. He's done a lot of research with cognition and cannabis, and he's done driving simulator studies looking at the effects on driving ability. And we have a lot of staff. And we have 2 ex-rugby players, 1 female rugby player and a male rugby player that have been our consultants, and they have very close ties to the rugby community, and they've been very, very helpful. And then we also have Marilyn Hustis as a consultant, and she's a cannabis scientist that's on the World Anti-Doping Association, prohibited list. She's an expert and an advisor. She knows the actual cutoff for the WADA is 200 nanograms per ml of cannabis, of THC in the blood. So they will let the athletes use it, but if they go over that, they could get in trouble. But she's been very helpful with assuring the rugby teams that this is okay with the World Anti-Doping Association. Implementation time, we just got the award in February. And I understand this cannabis research, I've been doing it for 20 years. It takes a long time when we get your grant to first enrollment. It takes about a year to go through all of the regulatory, going through the DEA, local, federal, the Human and Health Services. In California, we have to go through the research advisory panel. And we will have to get an FDA investigation, a new drug certification. It's all these things you have to go through. And we're hoping that the seasons start in January of each year. So we have a whole year to meet with the teams. And also, we've had a very overwhelming response from the rugby players. They are just like so supportive of this, and they said that they're not doing it. They're doing it because they want to know. They want to know if this and how we can help them with this. So, and then hopefully we will finish the study at the end of next year, and then we will be ready to look at it. Now, our goal is to. Hopefully, the next step is if we show an effect, we can actually go into the NFL players. This is just the Center for Cannabis Research, established in 2000. It's the biggest cannabis research team in the world right now. It's a very robust. They have laboratories. They have all of the facilities and equipment. We have study coordinators. It's a very, very robust research team, and they have a lot of experience in going through all the regulatory. And they've done a number of studies. These were just a sample of some of the studies that we've done. They're small studies, but that's because it's hard to do large scale multi-center studies with a scheduled 1 drug. I mean, it's about as good as we can get, but these were randomized double-blind placebo-controlled studies that all of them did show a positive effect, and almost all of them were in neuropathic pain. These are current and pending CMCR studies. We have a lot of studies. They're trying to do more studies with CBD, because we need more evidence for CBD. So summary, this is the first controlled study to examine the effects of THC and CBD in contact sports related pain relief in a real life setting. These will be elite rugby players. We've chose them because they are very similar. I don't know if any of you watched rugby. It's pretty brutal. I think it's actually more brutal than the NFL. But they assured us we will not have any trouble finding players with a lot of pain after their competition. The cannabinoids we selected reflect likely what is being used right now and what we know as effective dosing. And hopefully these will provide data regarding the possible effectiveness of cannabinoids for injuries. And then we can translate this into football players and hopefully eventually go into football players. And it'll hopefully inform us on larger scale studies to do in these elite athletes. And it's conducted by a very experienced research team with many, many years of experience in doing cannabis research. So thank you, and I'll have any questions. No, we're not. That's a good question. So, and understand that if we have, it's got to be feasible for us. If we did that, you're going to eliminate a lot of players, believe me. So what we've told them, what we're going to do is they will not use their cannabis. So they may be, so again, these are the start of the season. We're going to train them, and we've had some discussions with our consultants who've been talking to them. They said, listen, they're willing to refrain from it, but if they are dosing, you know, they do bottle 1 and they're not getting the relief they want, we will allow, we have to allow them to go back to their whatever they're using, whether it's an anti-inflammatory or their cannabis that they use. There's nothing we can do about that. Now we're gonna try to get them to refrain for the 48 hours if possible. But understand, I can't make them. This is the challenge of these studies. So again, we can't, we had a long discussion with them. We can't say that you can't use these medicines. So if they're on chronic opioid, but none of them are. I mean, very few of them, we would exclude them. But all of these players are taking something, not necessarily at the time of the competition, but they have after the competition. Yeah, some of them take an opioid, some of them take an NSAID, but we will track it. We will track it and see what they're taking. So,
hi, I'm Diego. I appreciate your comments about these guys that you're talking about. Of course, the incidents and our concern over the last couple of years is how they choose to manage pain, and that's what we've been studying, trying to empower them to learn how they can manage their pain, not using opioids, not using cannabinoids. But when this grant thing came out, I wrote a letter to Alan Sills and company saying I was really concerned about where this money was going. I really thought it should be pain management as a whole. When I heard about your study, I was extremely concerned about it. And the reason for that is the NFL players themselves are aged anywhere from about 19 years of age to convert.
Mhm, mhm.
I have a big concern with giving cannabinoids. But now it's kind of like you're creating a model that you're endorsing that use for them. I know they use it. I know we're trying to do is figure out.
So I acknowledge your concerns. And now, I acknowledge your concerns on exposure of cannabinoids to young people. And there's a thing with brain development and so forth. Now, understand that the doses, we're not talking about recreational doses. We're talking very low doses of THC. So the issues with brain development and the studies have been done. Most of those studies have been done in animal studies with animal models, huge doses of THC. And it's clearly huge doses of THC are going to affect brain development. Now, this is low dose THC. So it's very, very, and I've been doing this for 20 years. It's very unlikely it's going to have any effect on the brain. And look at the opioids. I mean, is it better to give them opioids? I do agree with your comment that we need to look at a comprehensive. I mean, we can't do that. This is a study focusing on one thing, but I understand that in your knowledge. So let's go to another question.
Yeah. Do you think that it acts more centrally?
So as far as peripheral or central? Yeah. So, and that's a good question. The cannabinoid receptors are found at all levels of the nervous system and even on inflammatory cells. So there's the mechanism, anti-inflammation is probably CB2 and inflammatory cells. And that's probably where we will see some of the inflammatory biomarkers, hopefully. That's what we predict. But there's also neurogenic injury and inflammation that can affect this neurogenic inflammation and then the CB1 receptor. But and then there's the brain with concussions. How's it working there? I mean, there's some evidence that the cannabinoids are neuroprotective if they're given early, and we don't know why. It may be because it's settling down the activity of the brain, and so the metabolic effect needs of the brain go down. So the half-life of cannabinoids is really short. I mean, it's metabolized by the liver very rapidly. And that's why when you ingest it, the first pass effect is super high, but it's stored in the fats. So if you use it chronically, yes, it's going to accumulate in the fat. So go ahead.
Last part. If it's the metabolite that is having this effect.
So metabolite? Yeah, so there is some, so it's hydroxy. The hydroxy THC is a metabolite, and it has psychoactive effect, and it has some cannabinoid effect. And the half-life of that is quite short, but it does have the 11 hydroxy gives you that second wave sometimes of psychoactivity. And in our studies with experimental pain, there was a correlation with hydroxy THC levels and pain relief. So there is probably some pain relieving effects of it. Okay.